How do you explain to an 8-year-old you have cancer? How do you tell them, here's what we do? My twin sister has a daughter, who's 8 years old, and suddenly was diagnosed with cancer right after Hurricane Katrina. So life was upside down, and it got worse. My sister was a nurse practitioner, so that helped. She knew enough, but still, how do you prepare yourself for that? You can't. What the doctor told my niece was, do you remember when you're little and you get scared at the middle of the night, and what do? Well, I go to my mom and dad's bedroom, and tell them I had a bad dream, and the doctor said, okay, so what you're going to go through is kind of similar. It's scary right now. It's going to be like walking down the hallway when it's dark, but you have a destination. You're going to be finished, and you're going to get help and relief on the other side. So you're going to walk through this, and it's going to be tough, but you can do it, just like if you were going down the dark hallway to reach your mom, to tell her you had a bad dream, and she would give you a hug and put you in bed with her and all hunky-dory. So today, that 8-year-old is now 21 and in college and doing great and volunteering at camps where she went as a patient. But I just thought that was a really interesting way of explaining to an 8-year-old where you could understand it.
Cancer is just something that we all have to recognize, acknowledge, cope with, live with, struggle with, rage upon, crush, and even thrive with. This show is more than knowing and fighting or beating cancer. It's more than just relaying science, hope, and technology. Together, our purpose is to demystify cancer, take away as much fear out of the diagnosis, treatment, and process as we can, defeat its grip on our lives. This is The Cancering Show. Dr. Butler, it's great to have you here. Thanks for coming.
Thank you.
Tell us a little bit about yourself.
I grew up in rural Tennessee, went to the University of Tennessee for medical school and graduate work, and trained at the University of Alabama at Birmingham in oncology. I'm an internist who is now a subspecialist in hematology and oncology, and now I focus on supportive care and cancer.
Fantastic. How about your day-to-day? Tell us about your clinical practice.
The clinical practice has been very rewarding to me. Because of the MCI and its devotion to a supportive care clinic, I've been offered the opportunity to have a supportive care or palliative care clinic. And that's been nice for me because it's not a traditional practice. It's a practice where I spend a little more time with each patient, getting to know the patients and their thought processes behind the diagnosis of cancer. And so that's been very helpful to me. Also looking and focusing on symptoms. In fact, a typical patient that would come in, the first question I would ask them is, what symptoms are you having from how do you feel going through your cancer treatment or your follow-up with cancer, and how is it affecting your quality of life? Are you able to do things you want to do? What are your goals in life? I mean, you're dealing with cancer. How are we making this into something that's a part of your life but not running your life?
I think that's the most important thing, that patients can still live their life with a cancer diagnosis.
Yes, I believe that's vital, and particularly patients who have incurable cancers. A lot of times when they hear the diagnosis, and if you say that, you can't cure the cancer, that doesn't mean that it's going to end your life. It means you've just got a different perspective on your life. I think that we can focus on looking at the positive things we can do to try to make their lives better.
Like what?
Well, today I saw someone who has an incurable cancer that's under control, and they're going to go on a cruise to Alaska. And I actually enjoy watching people enjoy their lives doing things like that. I strongly encourage people with cancer to travel if they want to. And we, in fact, they'll say, Doc, I've got a treatment scheduled for this time, but I may have to miss it for a week. I always tend to, unless it's going to be harmful, to favor quality of life over strict treatment adherence. I don't make that a 100% practice, but we try to work around it because the goal is to prolong comfortable life.
Absolutely. To keep people in their best selves and with their families as much as possible.
Yes.
Let's circle back to a patient who's in your office with a new diagnosis of cancer. How do you help them to cope with that initial diagnosis before you move on to treatment planning?
The way I usually approach that is try to be honest with the patient. I try to kind of frame the diagnosis in a manner where they can understand what's going on. I think you have to kind of know the level of understanding. And also in the initial appointment, I usually try to assess what their degree of desire for understanding is, because I think communicating with honesty is important, and I think patients need to be able to trust us that we're going to treat them like we would a family member, and that's what I try to focus on. But I think if you don't develop that degree of trust up front, I'm not sure how much they hear. Now, the other thing is initially with the initial diagnosis, sometimes it is so shocking that a lot of times you may have to revisit the conversation because you don't really know exactly what people hear. Most of the time when I come in, someone has already told them they had cancer. So the way I usually begin the conversation is, what do you understand about what's going on with your cancer process now? What have they told you? The next question I say, have they told you that it's curable or not curable? And try to put that in perspective.
That's fantastic. I do something similar myself. So I start every conversation by saying, what has your doctor told you about why you're here to see me? Because I worry that even using the word cancer might be putting a word in their mouth. And GYN oncologists, we do see a mix of patients with benign and cancer, as well as some people who are not diagnosed yet. So I agree. I think you always have to start with, what do you know? I don't know if you find this as well, but I often find patients, family members want to answer for them. And I have to stop the family member and say, no, it is a little bit of a pop quiz here that I want to know exactly what the patient understands so that they answer in their own words. What about distress? We know that patients are really in a state of shock or anxiety or depression immediately after that diagnosis. How do you address the emotional side of cancer treatment early on?
I think that for me, it's trying to give them a level of understanding. I think always using experiences of hope for the patients. I think letting people express their distress is important, though. And I think for me, the best technique is listening. A patient will usually tell me what's bothering them if I'll just listen. And that's why I'm so fortunate to have a clinic where I've been allotted some extra time to be able to do that. I think one of the main things is trust. And I think if I listen to a patient, they tend to understand that I'm wanting to hear from them what their experience is as opposed to what I'm dictating that their experience should be. And I think one way to say it is it's better to understand than to be understood. So I think that helps a lot. And I see a lot of fears be allayed just from that, just simple technique of listening.
For patients who maybe have a history of anxiety or depression that is exacerbated by this new diagnosis, how do you help those patients to manage their distress?
I think fear is one of the biggest issues that come up. And I think helping to cope with fear, we do have a counselor that is working in our supportive care clinic. And then we also have support groups. I think support groups are very helpful. I think that individual counseling with the nurses, I think opening the avenue for questions. I think a lot of times what I tell patients, particularly when they're starting their treatment, particularly when I'm talking about the first treatment or their original diagnosis, is the unknown. I think the unknown strikes up more fear than anything. And I tell the patients a lot of times when they'll come for their first visit, I say, this is probably the worst day of your cancer diagnosis. And that's because there's so many unknowns. You don't know what's it going to be like. Am I going to get sick? Is the cancer going to be life-threatening? What's going to happen? How's this going to change my life? And I think for patients to hear that we understand that that's hard for them, I think it helps them to trust us a little bit more, because it's hard to walk in their shoes because I've never been in their shoes, but at least I can tell them what my experience is with other patients.
And that, like you said, this is the worst day, but it's not the last day. We're here with you for this step and the one after that. I always tell patients the first treatment is the hardest because you don't know, but that the experience is going to be very similar for each dose after that, so that they can kind of become the expert of what they're going to experience.
Yes, and that's why I like to listen to patients tell about how their treatment is. because it helps me know what to tell other patients. I like to see the patient with the beginning of each cycle of chemotherapy. And the first question I ask on beginning of cycle 2 is, how was it? Now, if I hear that they've been sick and didn't call us, I chastise them.
I do the same.
If I hear they weren't sick, I say, hooray, this is better than what you thought, right? And so I think that gives a little bit of encouragement.
I had one patient accuse me of giving her the placebo. I said, ma'am, you're not on a clinical trial. That it's simply that she expected to have severe side effects and she had none. Hey, everybody, we're going to take a short break from our conversation for our innovation segment.
My name is Gary Piazza. I'm a professor of oncologic sciences at Mitchell Cancer Institute. I'm the chief of the Drug Discovery Research Institute. Pharmacology is the study of drugs and their mechanism of action. Cancer affects us all, but personally, my father died of esophageal cancer. He was a World War II soldier, and like many of the soldiers, smoked. Unfortunately, died of esophageal cancer. So the overall goal of our lab is to develop new drugs for cancer, and we're focusing on one target is RAS. RAS. RAS is a protein that's mutated in a high percent of human cancers. Over 90% of patients with pancreatic cancer have mutations in RAS. Over 40% in colorectal cancer patients, and over 30% in patients that have lung cancer. So it is indeed a target that is very well validated to be involved in cancer cell growth, but which we really don't have any drugs available for inhibiting RAS. If you were to give an analogy to a criminal, it would be on the FBI's 10 most wanted list. It is difficult oncoprotein to find drugs to fully inhibit it, and we have successfully identified a group of molecules that have high potency to inhibit the growth of tumor cells that have mutant RAS. Of course, there's many stages in terms of progressing an experimental anti-cancer drug into humans. We're at the stage of where we've identified a group of compounds. We've optimized them where they have incredibly high potency. They're very effective on killing tumor cells that have mutant RAS, and we have some preliminary data that they're effective in mouse models of cancer, particularly when the tumors are rapidly growing, and so the data looks promising. They still have a ways to go to get them into clinical trials, and this requires tremendous resources, so we're at that critical stage of their development.
It's so great to hear all the amazing things going on at MCI. But now let's get back to our conversation. Dr. Butler, if you could just walk us through kind of a patient is seen by their usually diagnosing physician that tells them they have cancer. They come to see you for that first visit where you may or may not have offered them specific treatment options or are waiting for more information, maybe like imaging or that tumor board discussion. And then what happens next?
Well, basically, I kind of look at things in a structured way, is that I need to know the diagnosis. I need to know the staging. I tell them that when I'm first meeting with them. If we don't have all the information in, I'll say we may need more testing. Most of the time when I first see a patient, particularly if they have cancer and not a blood disorder or disease, they'll ask what the stage is. And a lot of times I have to tell them, I really don't know yet. Right now, clinically, it looks like this stage, but we have to have further testing in order to know. And then I say, based on that, we will look at the options for treatment. A lot of times I'll just kind of judge from the patient whether they need to know at that time. I sometimes try to prepare them for the next visit by saying, this may involve chemotherapy, it may involve radiation, and just want you to be thinking about that. And that way they may come up with some questions.
How do you get a patient who is a bit overwhelmed with their diagnosis on track and moving on to treatment planning? Is there a particular phrase you use or a distress tool or a symptom tool that helps to then move into that treatment planning phase?
I think the first question I usually ask is similar to the one we asked at the beginning is, what do you understand about what I just told you and what our goals of therapy are? Do you have any questions or concern? I also have a little phrase, well, there's only one dumb question that you can ask, and that's the one that you don't ask. And also try to make sure the patient understands that they are the center of attention. It's not what I want, it's what they want. And so there's no such thing as a bad question. So I think giving them the confidence, try to give them the confidence that they can ask, what to expect.
The term for symptom management is palliative care, but a lot of patients see palliative care as a dirty word. How do you approach palliative care with a lot of hope?
Well, first of all, with the hope is I try to focus on the positives. I call myself a supportive care oncologist. If I use the term supportive oncologist, everybody says, well, all oncologists are supportive oncologists. But I tell folks that it means we're focusing on your symptoms. And palliative care has kind of a negative connotation because a lot of folks think of it as end-of-life care. And what I say is I tell folks that the word palliate means make you feel better. And I also tell folks that that's the goal of palliative care, is to make you feel better. It does not mean that it's putting an end time on your trajectory through your cancer, because I saw a patient 2 weeks ago that 10 years ago, I told them, you have incurable cancer. And not only did this patient have incurable cancer, but she relapsed once. And she's still here 10 years later. Now, she has symptom management issues. It's quite amazing that, we as doctors can tell statistically how someone will do, but the individual may do entirely different. And that's what I kind of focus on.
Dr. Butler, how do you address family support for patients? If family's not in the room, how do you really encourage the patient to get them involved?
First of all, I think family support is extremely important with patients. And I do see that when folks do have family support, they tend to do better as far as the management of their disease. I try to encourage them to realize that they're not alone and that the MCI, we have people that can help take care of them. But I always tell folks, particularly if they have strong family support, that what happens outside the office is as important as what happens within the office. And you can really see that when you have families that really engage in helping the patients. And it doesn't necessarily have to be families. I saw a patient today with a friend who came in, and he was diligent about managing the pain medicine and trying to help his friend. So I think you see a lot of love going between families and patients and friends and patients that really helps them through. I think one thing with cancer, the diagnosis sometimes makes you feel isolated, and I think knowing that other people are walking through it with you can be helpful. But we're actually seeing that we need to provide more family support in our supportive care and MCI resources because they are important. And also church members, I think, are important too. We see a lot of times patients will have church members that will help them out.
How does spirituality play a role in patient support?
I personally am a spiritual person myself, so I feel very strongly in the spiritual aspect of, I think it's all spiritual. To me, it's so gratifying to be in Alabama because there is a lot of strong spiritual beliefs in this community. So patients are not unwilling to share their spiritual beliefs. And I think that having a spiritual focus on the meaning of this disease and your life can be very helpful in a person in motivating them to do well during their treatment. And in fact, we have patients who have used their disease to minister to other people. And, it's kind of like I have this disease. Well, someone that walks in that has the same disease that's spirituality, them ministering to another person, one human being helping another. And you see so much of that in our practice. That's what's so gratifying, is to see that happening every day.
Absolutely. Actually, in cancer control and prevention, I'm looking to model a program called the National Witness Project, where cancer survivors literally witness in their churches, not unlike in the spiritual sense where you talk about your journey with God. But in this sense, they talk about their cancer journey as a way of motivating women to seek cancer screening services. So we hope to start something similar at MCI. This is a great way to wrap up the show because we want the Cancering Show to be not just about the patient or the treatment, but about the family, the spiritual experience, the interdisciplinary care, how it affects the community, really the whole process. Thanks so much for coming into the studio, Dr. Butler. I know how busy you are, and we really appreciate it.
It's my pleasure. Thank you.
Thanks, everyone, for listening to The Cancering Show with JYP, Dr. Jennifer Young-Pierce. Please subscribe, rate, and review this show on iTunes and anywhere else you listen to your favorite podcasts. Want us to deliver The Cancering Show to your email inbox? Contact us at cancering.com, and we can make sure you never miss an episode. We would love to know what you think about the show, or if you have any suggestions on topics you would like to hear. You can reach out to us on Facebook, Twitter, and cancering.com. Till next time, be healthy, happy, and always thriving.
This show is brought to you by the University of South Alabama Mitchell Cancer Institute. MCI is a cutting-edge cancer research and patient center built to fight cancer smarter in Mobile and Baldwin County, Alabama. Our researchers and clinicians focus daily on the struggle against cancer, serving a potential catchment population of more than 4.1 million people, with a singular focus of advancing cancer diagnosis, treatment, and prevention throughout the Gulf Coast and beyond with science, technology, and hope. Want to know more about the Mitchell Cancer Institute? Visit us at usamci.com or search for us on Facebook, Twitter, and Instagram. Mitchell Cancer Institute is a member of USA Health. To learn more about all of our hospitals, clinics, and services, visit usahealthsystem.com.